This right here is a condition, an emergency. You're going to see a lot inside of EMS. Someone calls 911. I can't breathe. They listen to the lung sound. We're wheezing bilaterally. They have asthma in their history. It's an asthma attack. Today we're going to learn what it looks like. What does the asthma attack look like? Understand asthma itself so we understand it for test day. And finally, well, how do we treat it when we're working in the ambulance? Here we go. So asthma is going to be our topic of the day. Now, before we can move any farther, we have to understand the key terms of what we're going to be talking about today. So first, let's define asthma and who gets asthma. So asthma is an acute spasm. What that means, anytime we hear the word spasm, I want you to think of tightening and constricting. For example, like a vasospasm is usually when it is constricting. That is, we're talking about the vasculature. Like if I say your coronary artery is under vasospasm, it's constricted, it's clamped down. This is an acute spasm of the bronchioles. The bronchioles are part of our lung tree, if you will. It's the pathways, the airways of the lungs is the bronchioles, okay? Oxygen going in, carbon dioxide going out. It's got to pass that highway of the lungs. That's the bronchioles. Now, in addition to excessive mucus production and inflammation causing obstructed and narrowed respiratory passages. Folks, did you hear that? We just defined asthma. So asthma is bronchoconstriction of the bronchioles, okay? Excessive mucus production and inflammation of the airways that cause obstructed and narrowed passages. What this means, why do you think we give the patient a duo neb, which is albuterol and ipratropium? Because albuterol is going to open up the bronchioles, the beta-2 agonist. And then the ipratropium does what? Dries up the excessive mucus secretion, dries them up. So now we're not as obstructed and we're not as narrowed, and now we can breathe. Now we're learning. Come on, let's continue now. Now look, asthma is most common in children ages from 5 to 17. Talking about children. That's an age you're going to see asthma, 5 to 17 in children. Of course, adults can have asthma attacks as well, but in the pediatric population, you'll see it around that age. Now, what are the factors? We're going to talk about it. Children and adults have different factors upon when an asthma attack will happen, and we'll explain what that is. Now, listen here. Asthma in children often resolves with age, but in adults, asthma is usually persistent. I'm going to give you a pearl before we continue. Just a pearl. Before we move on, your next patient with asthma, you're going to ask them this question. Have you ever been hospitalized with your asthma before? And if they say yes, have you ever been intubated for your asthma before? Have you ever had to go to the ICU with your asthma before, right? What we're trying to look for is this, especially in adult patients, okay? That's more of a question to ask for adults, okay? A child might not get that. But an adult patient, reason I ask that question, I want to know how bad their usual asthma exacerbation is. If they say, well, I have asthma, but, I've never been hospitalized before. I'm not saying they're going to be totally fine, but I know, okay, they've never had been intubated before. They never had to go to the ICU. Okay, maybe it's a normal flare-up, we hope. But if they go, oh no, every time I have a flare-up and call the ambulance, I always end up in the ICU. Okay, well now I know what I'm up against. That makes sense. Little clinical tip I had to give it to you. Let's continue. So we talk about extrinsic and intrinsic factors that involve the patient having a response and having an asthma attack. So on the extrinsic side, it's an inhaled allergen. On the intrinsic side, it's stress, infection, exercise, smoke, fumes, and aspirin. So what this means, for children, it is more of an inhaled allergen that causes them to have an asthma attack and call 911. Where for adults, usually it's stress, weather, infections, exercise, smoke, fumes, and we label there aspirin. Okay? So this some things that I've seen throughout my career that cause people to flare up. Okay? Pretty interesting. I thought I'd share it with you. So that's a little pearl. Let's continue. So what asthma is an immune system dysfunction causing it's part of the immune response, the immune system response that produces symptoms in the respiratory system and airways. I wrote down a big clinical pearl for you. There is no anatomic abnormality within the airways. What this means. So, folks, hear me out here. If somebody has emphysema, COPD, they're going to have changes to the structure of their alveoli, that gas exchange pad, if you will, where oxygen goes in, carbon dioxide leaves the body. You will have anatomic changes. You will have changes to your anatomy with COPD. Now, with asthma, it's simply an immune response that's causing a change of the bronchioles, okay? Asthma is classified as type 1 hypersensitivity, okay? So this gives you a little more background on asthma as we move forward. Now, if I was to break down asthma into 3 main parts, here's what I'd say. It leads to increased airway resistance, increased respiratory drive, and air trapping. Now, roll with me on this. Watch this. The excessive demand on the accessory muscles, we'll get to in a second, to compensate for the increased work of breathing is going to increase the risk of respiratory fatigue. If left untreated, we lead to respiratory failure. So folks, what are signs and symptoms of respiratory distress? Our heart rate increases. Our respiratory rate increases, right? We see accessory muscle use up in the neck, up in the clavicles. We see retractions between the ribs, pulling in between the ribs, right? We see anxiety in the patient. Respiratory failure, oh, I'm so tired. Man, I'm so tired. Everything slows. Heart rate slows. Breathing rate slows. They become not as responsive. They become altered mental status. They get cyanotic, bluing of the skin, right? Their vitals, their blood pressure goes down. They're heading towards arrest. This is in every patient, adult and pediatric. Now, the increased pressure in the airways and the thorax itself reduces blood return to the left ventricle, which can lead to decreased cardiac output and systolic blood pressure. So the top number of blood pressure and the ability of our heart to become a good pump. If left untreated, we get what I just talked about, hypotension and low oxygen levels can lead to arrest. That's in a nutshell. That is asthma. We're looking at it right here. Hope you're enjoying our lessons today. If you don't know, in the first link in the description is my video vault training. What you get there is access to over 480 videos and over 2,000 National Registry practice test questions. And we cover every level: EMR, EMT, Advanced EMT, Paramedic. This is where I send all my students, whether you're getting ready for school, you're in school right now, or you're getting ready for National Registry exams. You'll see this video right here. Go watch that video and I will tell you all about it. Let's go back to the lesson. So I remember when I was a brand new paramedic and we had to concisely define a patient who's having an asthma attack, but they're stable, and what signs and symptoms they will have versus what is severe asthma. Like we gotta throw everything at them like they're severe. I'm gonna show you what it is right now. So when we talk about an exam or the field, whatever it is, we're talking about what are the signs and symptoms of asthma, but just general. Here it is. Wheezing bilaterally. I'm going to put the sound of wheezing right here. Here it is. That's wheezing. You might even hear that across the room sometimes. It can be so loud. Okay, that's wheezing. So wheezing is a high-pitched sound that you heard. The sound created by exhaling through the obstructed airways. Remember, we have all that mucus inside of tight airways. So we have mucus plugging up airways that are already tight, and that's why they can't breathe, right? Again, it may be so loud you hear without scope. What's the deal with absent lung sounds? Well, maybe your instructors talk to you about, oh, your patient has an absent chest. So here's the deal, folks. If you go to a patient who's having an asthma attack, let's say, think about this, think about it. I listen on the right side and the left side, and I hear wheezing, wheezing, the front and the back, wheezing, wheezing. I can hear the wheeze, and I can see they're moving air. Okay, that's not good, right? That's bad. But do you know what's worse? I go to a patient, looks like they're not moving air very well. They look very stressed and anxious. Maybe they're not that responsive. They're not that alert. And I listen to their lung sound, and I hear absolutely nothing. Not on one side like a pneumothorax, different on both sides. Bilateral absent lung sounds. You know what we call that? An absent chest or a silent chest. That is a bad asthma, okay? What this means is, think about it. The lung sound had so much mucus and the bronchioles so tight. On exhalation, the patient isn't even making a sound. That's ominous. That's rapid transport. That's your lights and sirens, okay? The airway is completely obstructed that no air can get through, okay? What else do I see? Cyanosis, accessory muscle use, shortness of breath, a prolonged expiration, chest tightness. This is clear-cut asthma. This is a sick patient. But I want to show you some more things you might see, okay? I put here severe asthma. So what I'm talking about here is, here's our main, let's just say we're 30 minutes from the hospital and we get a sick asthma patient. They look like this. On the way to the hospital, maybe they look like this, okay? It can progress. So we have to find out, where are they on this scale, right? So let me show you some of the severe signs. Number one is this. If you can remember this the rest of your career, vital signs and mental status decide if the patient is stable or unstable in almost every realm. What's the mental status? What's the vital signs? That I can tell you, are you stable or unstable? So the first thing here is right here, decreased level of consciousness and altered mental status or agitation. They're not acting right. They're confused when they're normally alert and oriented, and they know where they're at, and they don't know where they're at, and you hear a silent chest. Whoa, okay? They're sweating profusely, okay? They're starting to show pale skin, retractions. Again, that's pulling in between the ribs. You can see that. The inability to speak more than 1 or 2 words, okay? Tachycardia, it's gotten so great that we're now over 130. That's rare to see, okay? Respiratory rate greater than 30, okay? That's, again, unstable vitals, right? Poor muscle tone and an end tidal greater than 45. That means, well, they're not ventilating very well. Correct. Okay. What else we got? So with asthma, I want to talk to you about assessment. So typically, they will present in respiratory distress when they call 911. We hope they're in distress and not failure. Remember, distress is, I'm still alert, I'm still awake, but I'm, having a hard time breathing. I got some of these things here, but I haven't gotten to the point yet where I'm confused and my vitals don't look good. Okay, that's failure. So they're probably going to be sitting bolt upright trying to breathe. Okay, if they're laying down, sit them up so they can breathe better. Okay, the tripod position like this, tripod position like this. Okay, accessory muscle use, the clavicle, neck, pulling, loud, rapid respirations, wheezing, mental status. Here are some of the signs of impending respiratory failure. I wrote them down for you. Confusion, nasal flaring, agitation, and they're so exhausted. I always tell my students, I did it for you earlier, I believe. Man, I'm so tired. Right? They essentially, you can see in the patient, they basically have given up. They've been trying to fight back this breathing, and it's just the point where the body physically cannot keep up with demand anymore. Right? They're starting to decompensate. It's not, the patient's trying their best, the body doesn't have any more fight in it, right? And that's why we're here. So let's talk about BLS management, and then we're going to talk about ALS management. So at the BLS level, well, what do you think is the first thing we need to do? First off, we need to assess the patient. We do our primary assessment, we determine they're in asthma. The first order of business is to get their oxygen level back up above 94%, right? Then we have two other things we want to think about with this patient in asthma. And let's say we're an EMT. Well, number one, do we have CPAP in our protocol? We probably do, okay? CPAP can help to keep that alveoli open and not collapsing, right? That can help, okay? It can also keep the airways, try to force with the pressure, trying to keep the airways more open. So if we can keep the alveoli open, try to keep the airways with the pressure of the CPAP more open, we may have a chance of actually getting more oxygen to our patient. So CPAP can be used in asthma, number one. Number two, with that CPAP, we're able to put albuterol, either whether it's through a masked nebulizer or, which I'll show you right here, I actually have one, whether we use something like this, which is a masked nebulizer, or we use something like CPAP, both of those devices we can administer with albuterol. So why do we use albuterol? First, let's talk about the oxygen. Adult target for SpO2 is 93 and 95%, at least at that level, okay? Children ages 6 to 11, our target is 94, 98%. Usually at a baseline, children have a higher SpO2 than adults. We want to get everybody above 94. That's trying to be our goal. If somebody has COPD, get them back to their normal, ask them what their normal is. If they don't know, we do our best that we can, right? We never withhold oxygen from a patient. That's a big key. Now, oxygen is simply going to raise the oxygen level. Albuterol is a beta-2 agonist. What does that mean? Well, what that means is this. Albuterol is going to go in the body. It's going to attach itself and act on the beta-2 receptor. When I turn on the beta-2 receptor, guess what happens? Bronchodilation. How amazing is that? So what we get is now we get an opening of the bronchioles. So it's all constricted in asthma. Albuterol can help open it up. Okay? Now, we're going to talk about it in a little bit. But do you know what else is a beta-2 agonist? Epinephrine. That's why I'll show you in a second. Paramedics can use IM, intramuscular, epinephrine to also help with asthma. Okay, we'll talk about that in a moment. Now at the BLS level, maybe we can do a breathing treatment, and we have oxygen, and we have CPAP as well. So we can think of the order as we give oxygen, we give a masked nebulizer, oh, they're getting really sick, give CPAP, oh, now they're not obeying commands, they're going unresponsive, now we got to take over the area with the BVM. We have no choice, right? They're unresponsive or they can't obey commands anymore, we can't use CPAP. That makes sense? Okay, so this is our treatment here for the BLS management. Okay, so now let's talk about the ALS management, our advanced EMTs, our paramedics. What do? So first, of course, we're going to look at same thing, BLS for ALS. Give oxygen, give albuterol, takes 2 seconds. Okay, we talked earlier about that duo neb. We can pop in ipratropium in there. Albuterol opens up the lungs. Ipratropium, dry secretions. Great. Well, we did that. Well, now what do we do? Get them on the heart monitor. While you're there, just do a full 12-lead EKG. Don't get tunnel vision. Not going to hurt. Print 2 out. You did your job. Good. IV access. Now, let's talk more about CPAP and BiPAP now. Consider CPAP and BiPAP. Why? CPAP and BiPAP are going to keep the alveoli open, which is where oxygen enters the body. Right? That's the whole point. So, in CPAP, the patient has to inhale and exhale against the same PEEP. It's more difficult to exhale because the expiratory pressure stays the same as the inspiratory pressure. Now, hear me on this, folks. If you have this in your ambulance, hear me out. In BiPAP, the patient can inhale and exhale against different PEEP. It's easier to exhale against a decreased expiratory pressure because they're having a hard time exhalating in the first place, right? Right, that's where the wheeze is coming from, right? So, listen here, folks. We want to consider levoalbuterol, albuterol, duoneb. Essentially, what's in your protocol, they all work. We also want to consider at this point steroids, okay, to reduce the inflammation. What were the 3 pillars of asthma? Bronchial constriction, I got too much mucus, and inflammation. So think about it, folks. Think about this. If I go to the patient and say, okay, you got a problem with your constriction. I'm going to open that up with albuterol and epinephrine. We'll talk about epinephrine in a moment, okay? Albuterol, epinephrine, open. Ipratropium, dry those secretions. Inflammation, let's do steroids like thiamidrol, okay? Like dexamethasone, right? We have that in the ambulance, folks, right? So we consider that. Then finally, some IV fluids. If there is some volume loss, you could just start them on some IV fluids and follow a local protocol. Now, you could consider IV fluids. The patient can experience volume loss from prolonged, increased respiratory rate. All that work or breathing, it can get them all dehydrated. So that's a thought to do. So this ALS management, we got a little more I want to share with you real quick. I am so proud to announce that the Paramedic Coach is now CAPCI accredited, and we're now recertifying your national NREMT certification. So if you're an EMF provider out there and you need CE and you need hours, you need to recertify, we now offer 100% online with me as your Paramedic Coach. You can do it right here on our website, recertification hours. You're going to see a link down in the description. It will say recertify your NREMT, something along those lines, and it will take you to a website that looks like this. Watch the video here. I explain the whole recertification process. You're going to love it, and I can't wait for you to see it. And back to the video. So on our management, and here we go. This is my final saying here, my final management tip. If the patient is not responding to treatment or for impending respiratory failure, for EMT, consider CPAP, as long as they're not hypotensive, as long as they're not unresponsive. It has to be able to obey commands with CPAP. Don't forget that. But EMT, worst case scenario, consider CPAP. AMT, consider epinephrine IM. Again, follow local protocol, but you should have it in there. Okay. Paramedics, this is where we consider our epinephrine IM and or magnesium sulfate. Remember this, folks? Mag in a bag. Yeah, there it is, folks, right? So we can give magnesium, which is what? Magnesium is a smooth muscle relaxant. So what do we say? I always tell my students, the worst, absolute worst case scenario in the ambulance. Let's say we've done everything. Oxygen, albuterol, CPAP. We've given the steroids. We've got everything. Patient's still not improving. Get out the magnesium, and you're going to hang that magnesium, okay? Remember, magnesium is in grams, okay? Not milligrams, grams, okay? Okay. Epinephrine dilates the bronchi due to its beta-2 effect. We already talked about that. Magnesium, smooth muscle relaxant. Now, what if I can't, well, we can give epi, of course, but with CPAP, for example, talked about this earlier, if they're pending arrest, are they going to be obeying commands? They might not be. Are they going to be hypotensive? Probably. Well, we can't give CPAP. What are we going to do? Well, now we have to take over airway control. Some pros to think about. They're either unresponsive or really lacking responsiveness. Okay? They're semi-responsive. There's a big mental status change. They can't obey commands, or when their vitals are unstable. You may have to take over airway control, assist with BVM ventilations if needed. If the patient experiences air trapping with positive pressure ventilations, they may need active decompression of the chest. And finally, folks, if we got a patient, unstable vitals, hypotensive, not obeying commands, we're probably not going to be able to give CPAP. So what do? We got to take over airway control. You may have to assist with BVM ventilations, and if you're a paramedic, take over airway control. And there it is. By clicking in the first link in the description, you get lifetime access to my Video Vault program. The Video Vault includes over 480 videos of content and now holds over 2,000 national registry practice test questions. Also includes some really awesome bonuses like worksheets, drug cards that are pre-filled out all for you, community group access to ask me questions, and audio files when you are on the go. The Video Vault will find you no matter where you're at, whether you're an EMR, EMT, advanced EMT, or paramedic student. And my students use this whether you are getting ready for school, in school right now, or getting ready to go pass your national registry exams. So click the first link in the description right now and get yourself lifetime access to the Video Vault today. I'll see you there.